Welcome, everyone. Please check our website for additional virtual patient seminars and in-person programs at www.macularhope.org. We are pleased to have you today. Our talk will be How to Prevent Diabetes and Protect Your Vision with Dr. Chows. We would like to thank the following sponsors: Regeneron, Apellis, Sun Pharma, eSight, Lumathera, MacuHealth, and Nodal Vision for their support of our programs. I'd like to talk a little bit about the Macular Degeneration Association. We are a 501c3 nonprofit. Our organization was formed in 2007 by our chairman of the board, Lawrence Hofheimer. His mother had developed age-related macular degeneration, and she lost her vision. And at the time she developed macular, there was no treatments of any kind, and he actually watched his mom lose the ability to see people that she knew, watch TV, do the crafts that she loved to do, and reading. So he vowed that he would form the Macular Degeneration Association so that everybody would have information pertaining to this disease. So following Dr. Chow's talk today, there will be an interactive question and answer session. Please ask your questions in the Q&A section only. Do not use the raise your hand button because we will not see them. At this time, I would like to introduce Dr. Chows. Dr. Chows is an optometrist with a private practice specializing in diabetes eye care and education in Tacoma, Washington. He attended Brown University of California, Irvine, and University of California, Berkeley. Dr. Chows writes and lectures on diabetes, nutrition, and macular degeneration in the U.S. and internationally. Dr. Chows has also written a wonderful book on diabetes, and I'm sure he'll tell you a little bit more about it. It is a wonderful book. It has a lot of great information. Dr. Chows actually does have diabetes, so if you want to know anything, Dr. Chows is the person. And Dr. Chows is on our the Macular Degeneration Advisory Board, and we are so thrilled to have him. Welcome, Dr. Chows. It's now yours.
Thank you so much, Donna. It's such a pleasure to be back with the Macular Degeneration Association. I want to thanks to everybody in the organization for inviting me. I'm going to share my screen now so that I can have something interesting, hopefully, to look at. There we go. So let me just hit the slideshow button. Yeah, so as Donna mentioned, I've had diabetes myself. Now, this is my 57th year. It's a long time to live with any condition. I got it when I was 5 years old. And it's type 1 diabetes, which is the less common form, but there's still 1.5 million Americans with type 1 diabetes. But, you know, there's like 40 million people with type 2 diabetes, far more prevalent than type 1 diabetes. And it turns out they have a lot more in common than most people think. And diabetes writ large, both type 1 and type 2, they remain the leading causes of new blindness in Americans of working age. So basically people under the age of 70. Let's see how we can advance the slide. There we go. So the fundamental question is, all right, prevention is a good thing. Why do we want to prevent diabetes? It's the same question we can ask about age-related macular degeneration, because they cause diabetes and macular degeneration both cause a lot of loss of visual function and quality of life. As I've already said, diabetes is the #1 cause of new blindness in Americans of working age. It used to be the case also, just by the way, I'll mention, in the United Kingdom, and it no longer is because they implemented a nationalized screening program for diabetic retinopathy where photographs are taken and sent to a central reading center. So people that have bad eye disease are contacted and treated before they lose their vision. But in the US, we rely on patients to self-refer, and that's problematic if you want to prevent complications and reduce cost, as it turns out. Diabetes is also the #1 cause of kidney failure in the US, the #1 cause of non-traumatic amputation, The risk of a heart attack and stroke and dying from one of those is 2 to 4 times higher. Double the risk of dementia. Some people refer to Alzheimer's disease as type 3 diabetes. There's a lot of overlap between diabetes and Alzheimer's disease. The brain itself makes insulin, and we know that that's one of the first things that goes south. Sorry, I'm hearing that there's a gardener's out here. He picked the perfect time to use the leaf blower. So the other thing is, and it's just like any chronic condition, right? Including AMD, managing diabetes is a pain in the donkey. That's what that's a picture of. So again, just a graphic, to demonstrate what I just talked about. Diabetic retinopathy affects the back wall of the eye, the retina, light sensitive, has lots of blood vessels. Diabetic neuropathy, actually the most common complication of diabetes. The nerves get affected all throughout the body. Diabetic nephropathy just refers to kidney damage. So again, the leading cause of end-stage renal disease, and then stroke and cardiovascular disease. Contemplating running outside and telling him to stop the leaf blower. So I show this to doctors just to remind them that diabetes complications only occur where there are blood vessels, nerves, and proteins. And that's everywhere. Every part of your anatomy has blood vessels, nerves, and or proteins, right? And so diabetes affects those tissues. So if you Google any disease and say, is this related to diabetes? The answer is probably yes. So there's a big misconception, which is that it's patients' fault entirely if they develop the more common form of diabetes, which is type 2 diabetes, and that it's due to poor lifestyle choices. In fact, excess weight is one of the biggest risk factors for developing type 2 diabetes, which again is about 40 million Americans. Another 100 million have what's called pre-diabetes, so they're at high risk for developing diabetes. But it's not strictly your lifestyle and your weight. There are a lot of environmental factors that are outside of individual people's control that increase the risk of developing type 2 diabetes. So let's just talk quickly about this. So these are two big studies. MESA is the multi-ethnic study of atherosclerosis, big study with multiple thousands of people. And NHANES, maybe you've heard of, it's the National Health and Nutrition Examination Survey. So this is about 90,000 people. And this showed that excess weight was the single, this is the key word, biggest risk factor to type 2 diabetes in the United States. So it accounts, probably for around half of the risk, maybe a little bit less than that. But what's also interesting to note, this is the but, is that if you look at genetics, genes, looking at all the different genes involved in diabetes, show that type 2 diabetes actually involves the processing of a whole bunch of genes, and that genetics actually account for somewhere, depending on what type of diabetes, how severe it is, somewhere between 30 and 70% of your total risk for developing type 2 diabetes is attributable to genes. That's the point I want to make. So just as an example, so if a mom who has a fetus developing is obese, gains a lot of weight, so that's referred to here. Don't get overwhelmed by all the details here. It's gestational weight gain. When that goes up, when mom becomes obese, even though she's gaining weight normally with carrying a child, lots of other things go wrong, including the stem cells that are passed on to her developing fetus. And those developing stem cells put that child, that newborn child, at much higher risk for becoming obese later in life, much higher risk for developing type 2 diabetes, whereas the opposite is true. If mom doesn't gain a lot of excess weight, the child is dramatically less likely, as a function of stem cells, to be a large baby. So if a baby is above 9 pounds, that's called macrosomia, that child, for the rest of his or her life, remains at increased risk for developing type 2 diabetes. So that's something obviously none of us have direct control over, because we can't control the weight gain that our moms experience, but it's just something we should all be aware of. The other thing I think it's really important, the estimates are that air pollution's been shown to contribute to type 2 diabetes, and about one in 5 cases of type 2 diabetes worldwide are directly attributable to small particles in the air, what we call smog, particulate air pollution that's small in size. So again, that's something that as individuals, we don't have great control over. You might try to move to a community that has less air pollution, and that would be wise for lots of reasons. Food insecurity. doubles the risk of type 2 diabetes. What does that mean? That means that people don't have access to or the resources to buy healthy foodstuffs. We tell people to eat fruits and vegetables and whole grain, unprocessed foods. That stuff tends to cost more money. So people that are of lower socioeconomic status often don't have the funds to buy healthy foods, or they're not educated about them. And so people tend to consume highly processed foods, cheap foods that elevate cortisol levels and increase the risk of developing obesity and also insulin resistance, which just means your body doesn't respond to the effects of insulin. And that's typical of type 2 diabetes. So I like this graphic just because it kind of throws together in one slide what causes diabetes. Everything causes diabetes. So here's a list of a lot of different things. If anybody wants this, let me know, and I can happily send you, this particular graphic. But there's all sorts of things here we don't normally think about, like breastfeeding. If mom doesn't breastfeed you as long, both she and her child, her baby, are at higher risk for developing type 2 diabetes. So the bottom line here is we've created what I call a diabetogenic, provoking diabetes environment. And obesity is not the only risk factor for type 2 diabetes. So don't blame patients for, the conditions that they develop, right? So there is a genetic component, just like, genetics are a primary determinant of who gets age-related macular degeneration. There are lifestyle factors, but these things interplay with one another, right? Genetics and environment. So these are my practical tips. I give this to all my patients that have prediabetes or who have family members with diabetes to help them try to avoid developing diabetes. Try to exercise 30 minutes a day. And I recommend people do it soon after waking, but also, again, briefly after they eat the largest meal of the day. Because if you exercise at those times, walking is a great way to do it. That improves insulin sensitivity better than at other times of the day. So after the meal for 10 minutes, early in the morning when you wake up for 20, 30 minutes. Eat a plant-based diet that contains a lot of fruits and vegetables, more vegetables, including, fermented foods. I'll talk more about that momentarily. Avoid processed meats because the preservatives in like luncheon meat, deli meat, those actually are damaging to the cells in the pancreas that make insulin. Drink coffee or tea. I'll talk more about that momentarily. Try to get enough sleep, but not too much sleep. Get your vitamin D levels above 40. There are studies that show, especially in non-obese Americans, if your blood level of vitamin D is above 40, it's nanograms per milliliter. You can get this done by asking your primary care doc to do a vitamin D serum or a blood test. You want that number to be above 40. So that does significantly lower the risk of getting type 2 diabetes. Smoking increases the risk. Don't do that. Live away from smog. I already mentioned that. Breastfeed if you possibly can, and the longer you breastfeed, the lower the risk. Turn down the thermostat at home. Indoor air temperatures have gone up a lot over the last 40 years, and that has been linked to an increase in obesity because your body doesn't burn calories as well when you're warm. When you're cold, it burns more calories. And then reduce light at night. All right, let me go to the next slide here. Oh, fast. Fast means fasting, right? So eat only at certain times of day, perhaps, or eat every other day. This is a way actually to reverse type 2 diabetes. I've done it with about 14 now. I've counted up 14 patients in my own practice that were really obese, were desperate to try to reverse their diabetes, and did alternate daily fasting. You eat a healthy diet one day, the next day you just drink water. And all of these folks lost more than 40 pounds, and almost all of them, their diabetes went into remission. It'll come back if they gain weight again, but if you can set your diabetes in remission, that's a good thing. You want to know if you're at risk for diabetes. So here's a website, which is doihaveprediabetes.org. People with prediabetes have blood sugar levels that are a little high, but not quite high enough to be classified as having diabetes. And this is a simple test you can do to find out, are you at risk? And it asks things like, what's your height and weight? Okay, you put that in, it's calculating your body mass index. So does anyone in your family have type 2 diabetes? Do you smoke? Are you physically active? Those sorts of things. Do you have high blood pressure? These are all risk factors for type 2 diabetes. And so you want to know, am I at higher risk compared to maybe somebody that doesn't have some of these risk factors? And then you can focus on preventing diabetes so you don't have complications of diabetes. So this was a big study done by the US government called the Diabetes Prevention Program, or DPP. So we now have about 30 years of data from this. And what was shown in this study is, compared to doing nothing, just being told lose weight and not doing anything else, people that walked 150 minutes a week, that's about 30 minutes a day, 5 days a week, were dramatically less likely to develop type 2 diabetes over time. Now, 30 years down the road, a lot of these folks are getting diabetes, but if you can delay it for 30 years, you're way less likely to get complications and have to live with, the hassle that diabetes presents. Just like we want to prevent AMD so that, you get it when you're 102, not when you're, 82 or 52. So this is just a summary of the diabetes prevention program. And all this says is that, at every time point, walking was better than just telling patients to lose weight. It was also about twice as effective as taking the diabetes drug metformin. Metformin is a great drug for lots of reasons, and it's actually linked to a lower risk of developing AMD. But walking was better than metformin. And I think this is something that physicians don't talk to our patients enough about, how beneficial just moving your body more is. So again, 150 minutes a week, 150 minutes of weekly walking reduces the risk. And this is in people at high risk. So people with prediabetes or people that had gestational diabetes, during a pregnancy. Now, I think this is another thing to bring up. Not everybody can walk fast, but if you walk faster, you lower your risk of developing type 2 diabetes even more. So if you can increase your walking speed by a little more than half a mile an hour, that little shift up in velocity lowers your risk of type 2 diabetes an additional 9%. And that's what this graphic shows. Faster walking is better for prevention. The other thing is that if you do develop type 2 diabetes, and so kind of, a number that I kind of tell my patients, try to walk 3.5 or more miles per hour if you can. And you can get apps on your watch, on your phone that tell you this. If you get type 2 diabetes, the people that walk faster, and that's all this shows, also have better blood sugar 2 hours after they eat a meal. That's what postprandial means. Postprandial just means after you age. So people walking faster had better blood sugar after a meal, and these people already had type 2 diabetes. So walking is good for prevention. It's also good for lowering blood sugar levels. Okay, the next thing to avoid diabetes, eat a Mediterranean type diet. So this is a big study out of Spain called the PREDIMED trial. And eating a Mediterranean diet cut the risk of developing type 2 diabetes by about 50%. The beauty here is that a Mediterranean diet also is very beneficial for helping prevent AMD, but also the progression of AMD. Lowers the odds of dry macular degeneration becoming wet macular degeneration. Eat a diet, and this is related to a Mediterranean diet, that helps your gut microbiome. So that's just the bacteria. There's also some yeast and other fungi, funguses, and viruses living in our intestines, right? So there are healthy bacteria and unhealthy bacteria. So if you want healthy bacteria that improve your body's ability to use insulin, you want to avoid processed foods, saturated fat, added sugars, and also, this is key, artificial sweeteners. So a bunch of studies show that especially aspartame worsens insulin sensitivity. It's also been linked to a higher risk potentially of developing AMD. Eat a plant-based diet that has lots of fiber. Eat fermented foods. Fermented foods, the good bacteria like fermented foods. What are fermented foods? Pickles, kimchi, sauerkraut. You don't need a lot. A little, a tablespoon of sauerkraut will significantly improve your gut health. Abnormal microbiome has also been implicated in not only diabetes, but in macular degeneration. So you want good bacteria, not bad bacteria. Eat a variety of foods that contain flavonoids. So flavonoids are simply pigments that are found in food sources, typically plants. So all of these things are good for our body generally, but they're also protective against developing type 2 diabetes. So berries, red grapes, tea, black and green citrus, kale, apples, onions, dark chocolate, but not in excess. Dark chocolate, but not milk chocolate, has been linked to lower risk of developing type 2 diabetes. And you don't need, what you want is a relatively small portion size, like a square every other day of dark chocolate. Hopefully, more than 80% of cacao. That seems to have more flavonoids in it that are protective against diabetes. A recent study that got published this year showed that a higher variety of these foods that have a lot of these plant-based pigments or flavonoids reduces diabetes risk by about 20%. So that's another thing you can do. All of these things hopefully are going to be additive, one on top of the other. Sleep is a big risk factor. It's also, as it turns out, a risk factor for getting wet AMD and severe dry AMD. So short sleep, under 6 hours a night, long sleep, more than 9 hours, have both been linked to developing type 2 diabetes. If you have sleep apnea, get it treated, because people that don't get their apnea treated are more likely to develop type 2 diabetes. They're also more likely to lose vision from diabetic retinopathy, which again is damage to the retina caused by diabetes. The final thing here is just kind of practical advice. When you look at a screen, like a computer monitor, your phone, before bedtime, it suppresses melatonin that is secreted by the pineal gland in your brain. Melatonin helps us sleep better, faster, more soundly. So don't look at your phone or any devices within an hour of going to bed. There are studies specifically in Japan that show people that look at devices like iPads, iPhones before going to bed, higher risk for developing diabetes, higher risk for all sorts of problems. So what else can patients do to lower the risk of getting diabetes? But rarely are they told about this by their doctors. So I'll make a little joke out of this stuff. Drink coffee. Multiple studies show that drinking coffee, whether it's caffeinated or not, reduces the risk of developing type 2 diabetes. But don't, and this is topical now, it's timely, don't drink instant coffee. And you may or may not have already heard this from other presenters, but instant coffee, in a recent study out of China with a lot of patients, people that drank instant coffee and also had genetic risk for age-related macular degeneration were 7 times more likely to get dry AMD than people that did not drink instant coffee. So you want to drink coffee that is actually brewed or coffee that you're going to buy from an espresso shop, but not instant coffee. It contains carcinogens and other ingredients that are damaging to the pancreas. So drink some coffee, but not instant coffee. What's my next recommendation? Breastfeed longer. I already kind of mentioned that. Breastfeed a little longer lowers mom and child's risk, and then avoid most artificial sweeteners. So I'm kind of circling back to what I already said. Consider fasting. I said that too. So coffee is protective. And again, it doesn't matter if it's caffeinated or not. There's something in coffee. It doesn't lower blood sugar levels, but coffee contains something called chlorogenic acid that reduces fat in our liver. And it's actually liver fat, fatty liver disease, that provokes insulin resistance and type 2 diabetes. And chlorogenic acid is good for your antioxidant defense system in the body. So for every for every cup of coffee you drink, there's a decreased risk of developing type 2 diabetes, about 11%. That's what the collective studies suggest. Breastfeeding, for every year you breastfeed, you're less likely to get type 2 diabetes, 9% reduction in risk. So it's good for you, as is drinking coffee. So I did the math on all this, my little joke. If you drink 20 cups of coffee a day, you can lower your risk of diabetes by 95%. Your hands may do this. That's not a good thing. I actually have a friend who's an eye doctor who ended up in the ER with tachycardia, super fast heart rate. He was drinking like a 6-pack of Mountain Dew. Mountain Dew has the highest caffeine of any beverage, apparently, per ounce of fluid. So don't drink Mountain Dew. 20 or more cups of coffee, and then breastfeeding your child until they're older. What did I say here? The age was 23, dramatically reduces, your risk of developing type 2 diabetes. If you combine the two, it's even lower. Obviously, these are not practical strategies. Just wanted to sometimes it's fun to take these studies with their statistics to the extreme. Okay, so I think this is a big deal. I'm just looking at my time. I'm all right. I hope you guys are all right, and I'm not driving you nuts. Wear a continuous glucose monitor. That's a CGM. These are everywhere now. You can buy them over the counter. So it allows you to see what happens to your blood sugar levels when you eat different sorts of food. And I've had patients, on the verge of getting type 2 diabetes that started wearing one of these devices, were able to completely reverse their pre-diabetes by just looking at what happens to their blood sugar levels. It kind of teaches you to think like your pancreas, like, how do I prevent my blood sugar from spiking? And again, you can buy over-the-counter options now. They're about $90 to $100 a month. I think that this technology is the most beneficial thing in diabetes care of the last 20 years, easily. Way better than the new diabetes meds because it allows the patient to take direct control. So these are what these devices look like. These are the prescription versions that are relatively expensive. So Abbott makes something called the Freestyle Libre. Dexcom makes a device called the G7, and they go on your arm. They can also go on your abdomen, is depicted here, and they measure in your fluid. There's a little wire that you insert, and honest to God, I've worn these now for 20 years. Virtually, no pain. Sometimes makes your skin itch a little bit, but they're measuring the glucose in your fluid that's under the skin, which is then correlated to your blood sugar level. So you get a reading on your phone that shows you, as is the case here, what your blood sugar is. And what's really nice is there's an arrow that shows you, is my blood sugar stable? Is it going down? So the person on the left's blood sugar is 71 and it's going down. That person's in danger because low blood sugar can kill you. The other person on the right, their blood sugar is high. It's 202. It's going up, but kind of at that 45-degree angle, if you can see the arrow. Basically, it allows you to think and act like a normally functioning pancreas so you can correct your blood sugar levels. Really helpful. You can see, like, what does a banana do to my blood sugar? It'll jack it up. I'll cut to the chase. These are the over-the-counter devices, and I don't have any financial interest in any of these companies. Maybe I have a mutual fund that owns the companies, but Stelo is made by Dexcom, and then the Lingo is made by Abbott. And you can buy these without a prescription and learn about your blood sugar levels. So consider fasting. I mentioned this already. When you fast, the diversity, if I can get it out, improves in your gut bacteria. More diverse gut bacteria help your insulin sensitivity, lowers blood sugar, also lowers blood pressure. You can get remission of type 2 diabetes, which I mentioned earlier in my own patients. And it's interesting, one Korean study found that if you skip breakfast, so that's intermittent fasting, you don't need, after you go to bed, you don't eat breakfast the next day, even though all of our moms and grandmas told us to eat breakfast, most important meal of the day and all that. But in this Korean study, people that did not eat breakfast were less likely to develop AMD, which is interesting. They did not look, though, at genetics in the study, so it's really not the perfect study. But fasting can help people prevent diabetes. So how do we prevent diabetes complications? Well, the good news is it's everything we've already talked about. So if you do all the things we talked about, walking, eating a healthy diet, everything we've already discussed, it lowers the risk of developing complications, including vision loss, that diabetes can cause. There's a few more things we can do, though, on top of what we've already talked about. So you want to know what's called your glucose time in range. All this means is what percentage of the day, week, month, 3-month period of time is your blood sugar in a relatively normal range. So this is specifically true in people that already have diagnosed diabetes. So a relatively normal range is between 70 on the low end, 180 on the high end. And you want your time in range to be 70% of the time or more, because this dramatically reduces the risk of developing severe retinal damage and losing your eyesight. Also lowers the risk of kidney disease. Hemoglobin A1C does not tell you this. A1C is kind of an average, not even really an average. It's got all sorts of problems. Checking your blood sugar by poking your finger at home and doing that a few times a day doesn't tell you this. These continuous glucose monitoring devices are checking your blood sugar, depending on the device, about every 5 minutes. So you're getting constant feedback. What's my blood sugar doing throughout the day? Time in range matters because if you increase your time in range, the risk of getting diabetic retinopathy developing or getting worse goes down by more than 40%. And it's totally independent of your hemoglobin A1C test, which is the test most people with diabetes know about. A1C is fine, but it's no longer the gold standard in diabetes management. Glucose time in range is the gold standard. The other thing is that if your time in range is better, and this is in people with type 2 diabetes, So if it's above 70% compared to under 50%, your risk of developing what's called major adverse cardiovascular events, or MACE, is reduced significantly, more than 30%. So that means a heart attack or an MI, myocardial infarction, a stroke, or needing coronary artery bypass surgery. Time and range is a big deal. To avoid heart disease and stroke, try to get your blood sugar, your blood pressure, and your blood cholesterol levels, especially LDL cholesterol. As soon as you're diagnosed, try to get them in good control. So the goal is A1C under 7%, time in range above 70%, blood pressure under 135/85, and your LDL bad cholesterol under 70. All these things lower the risk of eye disease, but also stroke, heart attack, coronary artery bypass grafting. To avoid kidney disease, heart disease, and vision loss, if you have high blood pressure, you should be on an ACE inhibitor or an angiotensin receptor blocker. So these drugs all end in pril or sartan. So examples, lisinopril. If anyone has diabetes out there, you probably are on this drug. Anything that ends in pril is an ACE inhibitor that protects your kidneys and your eyes. Sartans are drugs like losartan, telmisartan. Drugs ending in sartan also protect the kidneys and eyes. Ask your doctor, especially if you have any pre-existing heart disease, about the benefits of what are called SGLT2 inhibitors, sodium glucose transporter type 2 inhibitors. So these are drugs like Farxiga and Jardiance. They lower the risk of all sorts of bad things happening to your heart and your blood vessels. They also lower the risk of diabetic retinopathy. Now, if you're above ideal body weight, so that's the way I phrase it, so if you're 30 pounds or more above where you probably want to be ideally, you should ask about a glucagon-like peptide or GLP-1 drug. The best drug, in my opinion, is tirzepatide, which is known as Mounjaro. It also goes by the name Zepbound for weight loss. That's better than semaglutide, which is Wegovy and Ozempic. Same drug, just different names. And what you're trying to avoid is this: muscle loss. Some people call this Ozempic arm, because semaglutide causes loss of muscle tissue. Tirzepatide does not. Gets rid of fat in the muscle, but not the muscle itself. Consider fasting because it helps with weight loss, improves your gut microbiome health, and it's cheap, right? If you're treating your diabetes, you're trying to lose weight by eating less, that saves money. You're not spending, $400 a month on one of these injections to try to lose weight. This is critical. Get a dilated eye exam every year if you have diabetes, because just like AMD, the early signs of retinopathy, patients very often have no symptoms whatsoever. By the time a patient comes in and says, I'm having vision trouble and it's due to diabetes damaging their eye, it's really late in the game. Most people have a lot of damage by the time they notice symptoms. So you want to be checked every year if you have diabetes. Have a dilated exam, have an eye doctor look inside the eye. I'm a huge fan of using imaging, taking photographs of the retina and doing other kind of sophisticated analyses. Now we have artificial intelligence that helps us do an even better job. And that's becoming true in both diabetes and macular degeneration. Regular eye exams are the best way to catch early damage to the eye and treat them before patients develop symptoms. Okay, I'm turning to cough. I'm so sorry. Sometimes, you get that frog in your throat and it's like, I'm trying. Couldn't do it. All right. So we're near the end here, I think. So I get, that sounded, that's a forbidding sentiment to express. We're near the end of the presentation. My own diabetes specialist said to me like 20 years ago, he put me on a drug for early kidney damage and my numbers all improved. And he said, this is great news. And I said, thank you. I'm thrilled about this. And he said, but you're going to die at some point. And so, well, thank you for telling me that. That was thanks for ending our conversation on that optimistic note. I guess that's probably not the best bedside manner. So this is a big study done across 41 different countries looking at when do people show up for an eye exam that have diabetes. And it's really important to look at this data. So only 23% of people show up before they have any visual problems caused by diabetes, specifically diabetic retinopathy. About 70% come in after damage has already occurred. And a lot of that could have been prevented. There's this other unfortunate cohort group 8%, things were so bad that treatment doesn't work anymore. So you want to try to prevent people from falling into that category. But really, our biggest challenge is getting people in on time. And the problem in the United States, again, is we rely on self-referral. So maybe your primary care doctor says, oh, you've got diabetes, Mrs. Smith, go have your eyes examined. And that's all good and well. But is it actually happening? Patients a lot of times are told, do this, and they don't do it. So what they did in the UK, they started at every primary care doctor's office, called GPs there, general practitioners. They take an image of the retina, as I said earlier. It's evaluated by somebody trained to look at these images. And if people have sight-threatening disease, whether they have symptoms or not, and most of them don't, they're called in, they're treated before vision loss occurs. And they reduced the rate of blindness in England specifically by 75% caused by diabetes in about 8 years. Probably the same thing, especially as we're getting new treatments for macular degeneration, could be said. So you want to make sure, everybody listening to this call is an advocate for themselves, I suspect, right? You're interested in prevention. So you have to be your own best advocate. Make sure you go to healthcare providers, whether they're eye doctors or family doctors or endocrinologists or a retina specialist who's an advocate for you, right? That's going to keep you in the loop about new developments in diabetes care. So this instant coffee thing, it has to be proven, this Chinese study that says instant coffee dramatically increases the risk of dry AMD. But there are studies like that out there, and you want a healthcare provider that's widely read, that looks at emerging science, that doesn't just rest on data that might be 30 to 50 years old. So that's my push for my own patients to, get involved in their own healthcare, ask questions, and that's what I want you to do now. So what I will do, see if I can get my own face out of the way so I can do it. I have to stop sharing my screen. There it is, stop share. And now I can go to questions and answer. We got 7 questions. Okay, so I'll go in line here. So I'm just looking at the order. Okay, if you're taking medication for diabetes, will that keep my diabetes from getting worse? The answer to that is it depends. So, the medications that typically will make diabetes worse are drugs like the sulfonylureas, like glipizide and glyburide. They actually squeeze more insulin out of your pancreas. And there is some evidence that causes people to require insulin sooner than they would have otherwise. So it keeps you from having complications is what it does. In some people, insulin actually gives their pancreas a holiday so they can start making their own insulin better. This is specific to type 2 diabetes. So sometimes early insulin, low dose, helps people avoid a lot of insulin down the road. Next question, if you keep your A1 readings, A1C, hemoglobin A1C, is kind of sort of an average of your blood sugar levels over 90 days. It's not accurate in Black people or people of Mediterranean ancestry, and it's not even an average, it's a weighted average. But will that keep you from developing vision loss? Great question. Yeah, the general answer is yes, but it all depends on how soon after you're diagnosed you get your A1C under control. So people that have bad control the first 5 years, even if their A1C is great from that point forward, for the rest of their lives, they're at much higher risk for losing vision. It's called metabolic memory or a legacy effect. You got to get tight control early on after diagnosis. Okay, next question. What about these GLP-1 injections? Do they really work for those that have diabetes? They do. They work. If you stop them, most people regain the weight and their blood sugar goes up again. They've also been linked to a higher probability of having diabetic, so taking the shots like Ozempic, Wegovy, linked to a higher risk of diabetic retinopathy getting worse. And this happens with insulin as well. When your blood sugar drops really rapidly, very quickly, and a lot, the retina can't tolerate that, so the eye starts to bleed more. So I've seen this in multiple dozens of my own patients now. There's a whole bunch of literature out there about GLP-1s possibly harming the eye. Now, it's a risk-benefit analysis. If you lose weight and your diabetes control, you're less likely to have a heart attack or a stroke and go blind overall. But in some patients with eye damage already, the GLP-1 drugs can make things worse. So it says if your diabetes was brought on by a medication that you were taking, that's called secondary diabetes. By the way, Agent Orange is the most notorious toxin that causes diabetes. So people in Vietnam exposed to Agent Orange get way more diabetes. Will your diabetes progress? Can you end up with diabetic eye issues? Yes, yes, yes. If your blood sugars are high, you can end up with diabetes-related eye issues. Diabetes is diabetes as long as it's diabetes mellitus, mellis coming from the Latin for sweet. And that's how they diagnosed it eons ago. They'd taste someone's urine, and if it tasted sweet, they had diabetes mellitus, tasted like honey. There's other forms of diabetes way less common that don't do that. But if you've got diabetes mellitus of any sort from any cause, your risk of vision loss is high. You mentioned that saccharin was not good. So I didn't say saccharin, but it isn't good. I mentioned aspartame, but both saccharin and aspartame muck up your gut microbiome. So you have unhealthy gut bacteria that leads to more inflammation. Truvia, is it Truvia? I'm not sure. I'm not familiar with Truvia. It's probably another artificial sweetener. The one that I have had pretty good luck with is stevia. I think that's a reasonable artificial sweetener to consume. But excess of anything is probably not good for you. I've tried fasting, but my blood sugar drops too low. What can I do? Well, if your blood sugar, so is it really dropping low? So the only people whose blood sugar is going to drop low are people that are on insulin therapy or a sulfonylurea drug like glipizide or glyburide. Metformin does not cause low blood sugar. If you don't have diabetes, fasting, it may lower your blood sugar, but you're not going to get severely hypoglycemic. And the way you find out, you wear a continuous glucose monitor. Are you really low or are you having false lows? A lot of people, because their sugar is elevated all the time, when it gets into a normal range, they get symptoms of low blood sugar, even though they don't really have low blood sugar. Do you recommend eye doctors in local stores such as VisionWorks? Do you still get the same exam? That's a loaded question. I'm not going to offend anybody. I would ask any eye doctor, do you have a lot of experience with diabetes? Ask them about their knowledge about diabetes. Here's the reality. Most eye doctors, and I talk to them all the time, don't know a lot about diabetes. They know a lot about the eyes and about how diabetes damages the eyes. Talk to your specific provider. This is a simple question. Do you see a lot of people with diabetes? If they're going to work, they are, because every other patient has diabetes or prediabetes. And then just say, can you give me any advice about how to prevent vision loss from diabetes? And it shouldn't just be, control your diabetes better. It should be specificity, right? Try to keep your glucose time in range above 70%. Wear one of these continuous glucose monitoring systems. Any eye doctor you go to should be dilating your eyes. I know a lot of eye doctors have started using these cameras that are wonderful, that you can get a view of the retina, that's excellent. I don't think they're as good as dilating the patient's eye. It's just much easier to miss problems as a doctor if you don't dilate the patient's pupils. How protective is tea in preventing diabetes? So, like coffee, a bunch of studies showed that tea, both green and black tea, lower the risk of developing type 2 diabetes. It's probably the flavonoids, these pigments, these chemicals in foodstuffs that are protective against insulin resistance. So explain details about how to fast. How many days should you fast? So there's 100 different fasting regimes. So one that's pretty common is don't eat at night, skip breakfast the next day. That's called time-restricted feeding. Time-restricted feeding, TRF. So one strategy is to say, okay, I'm only going to eat. I won't eat in the morning. I'll eat from 6 to 10 at night, 4-hour window. The rest of the day, I'm not going to eat. So that doesn't work as rapidly for weight loss. Jason Fung, who's a famous kidney doctor in Toronto, Canada, he's written like 12 books on this whole subject. His advice is to do alternate daily fasting. Eat one day, a 1,500 calorie Mediterranean type diet. The next day, just drink water, unsweetened tea, or unsweetened coffee. And so alternating days like this, you get more rapid weight loss. This is an ideal strategy for people that are 40 pounds or more above their kind of target or goal weight. As I said, it can cause remission of diabetes. Now, I have one female patient that's done it. All the rest have been men. And they all had one thing in common, the men. They were put on insulin, gained weight, because insulin causes weight gain. And all but one of them had erectile dysfunction. And if you want to motivate a man, you tell a man your sexual quality of life is going to be better if you do this program. So I've been able to get men to kind of buy into this fasting regime. Women are way more sophisticated, smarter. So probably need to come up with other strategies or additional strategies to help women. I think that fasting is a great underutilized strategy. You can Google and say, talk to me about different fasting regimes and try them. See if they work for you. If you're on insulin, you got to be careful. So you want to wear a continuous glucose monitor so you don't get severely low, because low blood sugar can make your heart stop if it gets too low. You don't want your blood sugar to be under 70. It also increases the risk, by the way, of having worse diabetic retinopathy if you have a lot of low blood sugars. So high blood sugar is bad, so is low blood sugar for you and your eyes. Okay, if you're put on insulin, can you ever come off of it? Yes, you can. Generally, people don't, and the reason is because they're not put on insulin until their pancreas is kind of burned out. It's run out of gas. So there is evidence that if you start low amounts of insulin by an injection or an insulin pump, which is what I wear, there's even an inhalable insulin that's available called Afrezza. I don't work for them, just so you know. If you take low doses of insulin early on in type 2 diabetes, it seems to delay the need down the road for having to take insulin injections all the time. It's really important to know that about a third of people with type 2 diabetes end up on insulin and require insulin to keep their blood sugar levels relatively well controlled. So we don't say insulin-dependent diabetes anymore. That's an anachronism. It's not in vogue. It's type 1 and type 2 diabetes. Half of people with type 1 diabetes get type 2 diabetes laid on top of their type 1. And a third of people with type 2 diabetes end up dependent on insulin. So again, as I said, there's a lot more overlap between type 1 and type 2 diabetes than most people realize. Type 2 diabetes, in my opinion, is the worst form of diabetes to have. Those patients tend to have more cardiovascular disease issues, higher risk of cancer as well. No diabetes is good. It's just like, what's the good kind of AMD to get? There is no good kind of AMD to get, right? You want to prevent age-related macular degeneration. A lot of it's beyond our control. My dad had early AMD when he died, but his older brother, lost vision from wet AMD. And, it was back in the time when there were none of these medications available to prevent severe vision loss that we have now. And, I think it's really good to try to catch things early, but prevention beats cure over and over again, right? So no open questions at this time. With that, I'll shut up. It's 10:50. Did I go too long? I think I was actually supposed to stop I'm on the West Coast, sorry. So 10:50, I know it's later for many of you. I'm grateful that everybody, joined me today. I know I talk quickly. If anybody has any other questions, I'm happy to answer them. You can email me. Did I have my email address up there? I'll just tell you what it is. It's DR, like doctor, _ my last name, which is CHOUS, Chouse, at diabeticeyes.com. One word, plural. And you can also send them to Don or Andrea at the Macular Degeneration Association, and they can forward those to me. And I can, if you want to include your email, I can answer you at length if you have questions. I'm passionate about patient education. I've been to a lot of doctors that say you're fine and come back in 6 months. That's not good healthcare. Good healthcare is engaging your patient, if you're a doctor, and you engaging with your healthcare provider. How do I prevent things from getting worse? That's the fundamental question. And I think that's a big reason why a lot of patients are turning to non-traditional forms of healthcare, because they're just not getting the collaborative healthcare experience that they want. Every doctor wants his or her patients to do well, right? But some docs, I think, are better about working with patients collaboratively. And that's what we all deserve, right? If your doctor's not doing that, ask your friends. Do you have a doctor that works with you, that collaborates with you, that listens, to your concerns? It's really important if we want good healthcare. I have 2 sons, and they both told me, well, yeah, humans are great, but AI, artificial intelligence, does a better job. And that's the reality in terms of detecting disease. I have a third cousin who's a colorectal surgeon at Duke University, and he said, yeah, AI can pick up colon cancer better than I can. But what it can't do is talk to patients empathetically about treatment options, about prevention. It's not a human being, at least yet. So with that, I'll shut up. Donna, anything else you want me to say or address?
Yes, Dr. Taos, I got a question for you. Somebody sent it to me. They said that they've heard about all these liver cleanses, that they were good for diabetes and all these other diseases, and they
Yeah.
wanted to know what your thoughts on that was, if they should consider taking them or if it's a lot of hooey.
No, there's a lot of hooey out there, especially if you go to Dr. Google, right? So what you want to look for in any kind of treatment is there has a study been done that was a randomized controlled study, right, where a placebo was compared against the treatment. And I don't know if there probably are around some of these liver detoxification schemes. My wife gives me a tea. I'm trying to remember. It's like milk thistle tea that's supposed to be a liver detoxification type of tea. And I don't know if it works, but I drink it on the hopes that it might. Here's what we do know about the liver. Fatty liver disease is directly responsible for type 2 diabetes and insulin resistance. So how do you reduce fatty liver disease? By being of lower body weight, that helps. But can you specifically get rid of fat in the liver? So this is a really interesting thing I'll just address quickly about fat in the liver. So one study looked at obese patients. So their body mass index was above 30. That's generally used to describe obesity. It's not perfect, but generally it works BMI. So some of these people had type 2 diabetes, some didn't. And I have a lot of patients that are obese, don't have type 2 diabetes. I have skinny patients that have type 2 diabetes. It's not all about how much weight you have, but how much liver fat there is. So in this study of obese people with and without type 2 diabetes, the difference when they did ultrasound and MRI of their livers was 1 extra ounce of fat in the liver. So if you can get rid of that 1 ounce, not very much of fatty liver, you can reduce the risk of type 2 diabetes. So the only drug I'm aware of right now that reduces fatty liver disease, doesn't work in everybody, is tirzepatide, which is, I don't work for the company again, that's Mounjaro, and it also goes by the name Zepbound. It's a weekly injectable that in some patients reduces their fatty liver disease by up to 90%. So if you're above ideal body weight, I think tirzepatide is going to be used for diabetes prevention in low doses. Dr. Gerson, who I know is your medical director for MDA, he and I do a lecture every year about what's new in diabetes care, and we give it to eye doctors around the country. And one of the things that we've been talking about is low dose, micro dosing of these drugs that are expensive. If you take a lower dose, doesn't cost as much, has fewer side effects. The liver detoxes, I would be skeptical about. Show me the data, show me the evidence, and then maybe it's something you want to consider doing. It's a great question. Every one of these questions we could talk about for an hour, and ask your own healthcare providers too. What does your family practice doctor know? And the odds are they're not going to know a lot about it because they're humans, right? And so again, it's really important. Try to find healthcare providers that read journal articles, that don't just read the abstract, which is like the summary of an article, but dig through it. And probably people on this call have heard this before. The ARIDS-2 study, said, lutein and zeaxanthin don't help AMD. It wasn't significant, but it was if you looked at the people that didn't consume lutein and zeaxanthin in their daily diet. So every study has caveats, and if you only read the summary, sometimes you miss the forest for the trees. That's my statement about that. Sorry, Don, I go on 10 minutes when it was like probably a 30-second answer I should have given. Is there something else here? Another question and answer? I'll see. Because I don't know. I have 4 minutes, it looks like. Can you reverse prediabetes? What is the A1C number to be below? Yeah, so no, 7 is diabetes. So you want your A1C to be under 5.7. If your A1C is between 5.7 and 6.4, you have prediabetes. 6.5 and above, you have diabetes. So talking about 2 separate things here. So you can reverse prediabetes. That's what the diabetes prevention program showed. Everything that I was talking about earlier can prevent prediabetes from becoming diabetes, and you can get rid of your prediabetes by walking, by eating a healthy Mediterranean type diet. Don't the weight loss injections make wet AMD worse? That's a great question. Dr. Gerson and I have been talking about that. So it doubles the risk, is what one analysis suggested. Hasn't been confirmed, but in one analysis, the likelihood of wet AMD was doubly high in people that were on these drugs. What they didn't look at, though, in the studies was the patient's genetic risk. By far, the biggest risk for AMD are your genes. And that's why I still am personally a fan of doing genetic testing in AMD to find out what is your risk based on mutations called SNPs, single nucleotide polymorphisms. These are little point or spot mutations in your DNA that have been strongly linked to macular degeneration, about 70% of the risk. And so knowing your genetic risk is helpful. The other 30% for AMD is, environmental. So then if you're at high genetic risk, you really want to focus on the environmental things like, not smoking, the number one thing, not eating a lot of sugar. That also increases the risk of wet AMD. So you don't activate the genes that you inherited at no fault of your own from mom and dad. And always remember, mom and dad gave you all the good things that you have, right? All the good traits. So, I had a patient the other day, really wealthy stockbroker guy that said, yeah, I've got AMD. My mom gave this to me, but your mom gave you everything good too. Your mom loved you. It was not intentional. I'm sure of it. What if you have wet AMD already? The question was, if you already have wet AMD, will taking a glucagon-like peptide drug like, Wegovy, Ozempic, is it going to make it worse? It might. And that's actually what the authors of the study said. Yeah, if you already have wet AMD, make sure you talk to your retina specialist, and they're not going to know the answer is the reality. But if you're already getting injections, you might need more injections if you go on one of these drugs to lose weight. It's something to be aware of. At least we have a treatment for it now. And now we're getting these treatments for dry AMD, one of which, so I know Lumathera is a sponsor, and they're close to where I'm sitting right now, using light therapy to make dry AMD better. And their studies, one done at Stanford University, showed that it actually improved people's vision. So that's something, if you've got dry AMD and you're trying to prevent it from getting wet, even if one eye is already wet, you might want to talk to your retina specialist or your regular eye doctor, optometrist or ophthalmologist about, using light therapy to get rid of drusen and lower the odds maybe of converting to wet AMD. Use the 4C Home device. I'm a huge fan of that. I think it has applicability in diabetes as well. But, it's Notal's device is marketed to people that have AMD, obviously. I think they're a great company. I highly recommend to all my patients with dry AMD to use that device so that if they convert to wet, they catch it sooner. The sooner you catch it, the better the outcome is for you from a vision standpoint, maintaining your driving privileges, for example. Okay, went on too long again. I'm sorry. No open questions. Please email me if you have any, or email Donna or Andrea, and I'm happy to. I get back to everybody that I'm kind of obsessive about it. I don't want to leave things out there if people were not sure about what I was saying or meaning. I know I'm a little bit of a fast talker. My patients and staff tell me that all the time, and I'm constantly running behind in my office because I really try to treat every patient like they're my own family member, and I think that's what we all want in a healthcare provider. Donna, thanks so much for inviting me. Thanks to Dr. Gerson for inviting me as well.
Well, Dr. Taus, thank you so much for the wonderful presentation and all the wonderful information that you provided to us. I believe everybody has come away with a lot of great information and now understand more so. So I want to thank you all. And then I want to thank everybody that participated in the program today. Wonderful questions. Thank you so much. Please go on to the website, look for additional virtual programs as well as live programs. There are links there for you to sign up, and we'll see Dr. Chaus again in the future here. Thank you again, and you guys all have a wonderful afternoon. Bye-bye.